world. When we look at type 1 diabetes, yes, the management, we would definitely look at it as any other child without type 1 diabetes. We have to give well-balanced meal, and especially in a country like India, where we are so diverse in our food habits. North eats so differently to east, to west eats so differently to south. So we have to keep their cultural preferences, religious, beliefs into consideration. And it has to be a well-balanced plan in right quantity, definitely focusing on quality, because we have to focus on growth and development. So therefore we tell these parents that it's very important, just don't look at carbs alone. We have to make sure that we're giving very well nourished, balanced meal to these children, because we have to also focus on the growth and development, and of course on other aspects as well. The goal is to maintain normoglycemia. Very important is to prevent hypoglycemia, prevention of complications. And while we're trying to target an HbA1c of, say, less than 7% without any hypoglycemia, and today we're looking at time and range, where most of our children now are using the CGM devices. So definitely focusing on better glucose control in terms of minimal glycemic variability. And that is the focus area for us as dietitians as well. And definitely with people with, with children with type 1 diabetes, also looking at if the child is diagnosed with hypothyroidism or celiac disease, the meal plan will definitely need to be tweaked according to these conditions. Now, we start carb counting, or we start with the entire education right from diagnosis. So this is extremely important. So it has to be, we take a detailed, in fact, sometimes in our clinic, we spend more than 2 hours with one family, the first consultation itself, and it doesn't end there. We're continuously in touch with our families, because it's not something that can be taught to them on one first day, because they're so overwhelmed with the diagnosis. They don't understand carb, protein, fat. I'm sure most of us, unless you're not in this field, we eat food. We don't really understand carb, protein, and fat. So one is the diagnosis is very, it's like an earth-shattering moment. Then comes insulin and everything else. So it has to be done in a very stepwise, maybe multiple follow-ups with the, with the family, with the child. Assessment and dietary recall is very important, is to assess what they were eating before the child was diagnosed, because when they're, before we see that they will have a packet of biscuits with milk in the evening, or even in the morning, they may just have a glass of milk and go to school, or sometimes not even have anything. So again, trying to understand what was their routine before, what is the kind of activity that they were doing, in terms of a lot of children, indulge in physical activity, be it in school or even otherwise outside of school. Then we calculate the energy and nutrient requirements. Then we look at, we focus on principles of healthy eating. That is where we begin. We start telling them, and one is we focus on the entire family changing their food habits, because it's not only the child who's diagnosed. And most often, initially when the family comes to us, they're very upset that, why my child, etc., etc. But after a few months, the parents actually come and tell us that, I had pre-diabetes, or my glucose levels were deranged, my lipids were deranged, my weight was above the healthy weight range, and now everything has come back to the normal range. It's only because of our child. Because our child is eating healthy, we've started eating healthy. So there's a very positive kind of an association then that they develop with diabetes, and of course with food. Again, when it comes to type 1 diabetes, we have to focus on synchronizing insulin with meals, because these children may be on different insulin regimens, maybe sometimes on rapid acting or sometimes on regular acting. So again, the meal plan will need to be customized depending on the insulin regimen. Protein and fat counting comes much later. We don't start with it. We would maybe take a couple of follow-ups and then focus on that, because otherwise it becomes too much information at one go and they really can't do anything at all. Hand-holding and timely follow-up. And that's why even in our setup, we definitely have an educator. We have a pediatric diabetes educator. We have a pediatric dietitian who's constantly in touch with these, families, because otherwise they can't understand everything. And again, in our Indian system, it is sometimes the grandmothers, parents are working, sometimes the grandparents are there, then you have uncles and aunties. So everybody, needs to be counseled and educated on the management. Energy requirements is similar to any other child without diabetes. Again, if you look at the RDA, the requirements are pretty high. So we first look at what is the dietary recall, what is the requirements, and then focus on it. Again, sometimes because of taking too much of insulin, repeated hypoglycemia, as the child starts gaining weight, sometimes even not using the carb counting properly, because they think that, okay, if I'm having to count carbs, I can just eat as much as I want and eat unhealthy and just keep bolusing insulin. So again, their principle of healthy eating becomes extremely important. The requirements would again differ depending on the, the child is in the pubertic age group, or maybe even if the child is doing any kind of extra activity which demands extra nutrients. This is as per the ISPAT guidelines. So again, the carbohydrate recommendations is between 40 to 50% of calories coming from carbs. Moderate sucrose intake. We definitely want the sucrose intake to be less than 5% of energy. We would not really focus on giving them diet foods. A lot of parents ask us, can I give a diet cake or a sugar-free mithai, etc., etc. But I think there, what I see is then people don't realize that that sweet has also got carbs, because they may be adding some grain, whether it's maida or wheat. So it does have carbs. And then automatically these children start eating more because they think it is having no calories or no carbs. So again, we tell them to eat the regular things. So if they're making a kheer, then you have the kheer with the sugar, obviously moderate the amount of sugar and have it in bolus for it. I think that's a very, very good way of, then the children don't really feel that, they are deprived of things, or they don't feel any different. And we calculate it in the total carb intake. Fat for children less than 3 years, 30 to 40% of energy, and 4 to 18, 25 to 30% of calories coming from fat. Definitely, the saturated fat needs to be kept below 10%. And if that is dyslipidemia, it is less than 7%. Intake of trans fats. Here, again, MUFA fats become very important, because when you're looking at children, they obviously are hungry, and then they would want to eat something which is maybe lower in carbs in between, and nuts become a very, very good option. So in terms of, almonds, walnuts, pistachios, or even peanuts for that matter. So they become good additional MUFA fats, and they also help to meet the calorie requirements, which is required. So definitely, we focus on incorporating nuts, again, depending on the affordability of the family. Protein, 15 to 25%. So we go as per the ISPAT guidance for protein. And protein does help to blunt the postprandial blood glucose levels. And we know in India, we're a protein deficient country. So the focus has to be on, moderating the carbs, improving the protein quantity as well as quality, as well as giving good quality fats. And that ways we get a good postprandial blood glucose control. Fiber, again, the focus is to improve. This is something which is a challenge, because most often parents tell us that children don't eat vegetables at all, and they struggle to add vegetables or any kind of, fruits and vegetables to the diet. So again, looking at ways on how we can actually add, vegetables in the diet is something that we definitely focus on. We give them recipes in which, they can maybe, try different recipes which have got more fiber. That also helps in blunting the postprandial glucose. Now, off late, I've been seeing in my 24 years of practice, honestly, in the last few years, I've been seeing a lot of parents who come to us and tell us, give us only 20 grams carbs a day. Give us only 50 grams carbs a day. We don't want more than that. Because what happens is they're on these WhatsApp groups, and a lot of adult type 1s are putting in their, CGM trends, and it's all a flat line. And that is where they try and chase that fat line. And they, in fact, sometimes if we tell them, no, it's not good to do, they will go to somebody else, or they do it on their own. And then they realize that it's very difficult. One is sustainability is very difficult. Again, our children, they're going for birthday parties, they're going for picnics, they go to school every day, they're sharing, the tiffin break is with the family. So, I mean, with the other friends in school. So we actually discourage them. And even ISPAT guidelines very clearly, even today in the guidelines, it's mentioned that you should not really go very low on carb, because one is it's not sustainable. There can be a lot of nutrient deficiencies, growth failure can happen, and as well as I think it does result in eating disorders in the future. So definitely, and honestly, in our practice, we give around 45 to 50% calories coming from carbs, and we get excellent blood glucose control. So there is no need to go very, very low on carb. Conventional method was feeding for the insulin, because we were always worried about hypoglycemia. So we would feed for the insulin. In today's time with carb counting, we give insulin for the food. So you want to eat less, you take less insulin. You want to eat more, you take more insulin. So of course, the focus is to add more flexibility, variety to the diet, and help the child befriend their diabetes and not have any negative association, whether it's diabetes or with food. Because we've seen that the children who have been deprived in the past, they now, when they're able to take their own decisions, in fact, they go overboard, especially in the adolescent years, they become very, very rebellious. And then sometimes they don't take insulin, or they will eat what they want and don't bolus. And we see their A1C levels are very, very high. Now, if you look at our Indian food, like even today, our lunch you would have seen was so different to what we've maybe normally eating. And today, what we realize is when we take dietary recalls, the dinners have been replaced by snacks. this whole snackification of our meals, which is okay, we can healthify it, but very important is the nutrient content differs every day. Sometimes you take more carbs, sometimes you take less carbs. And therefore, if you take the same amount of insulin, it can result in either hypoglycemia or hyperglycemia. And therefore, carbohydrate counting becomes very beneficial because it helps to match the insulin to the amount of carbs that the child wants to eat. I remember in the past, he used to tell the child, don't eat that extra roti, don't have that extra bowl of rice, because we were worried that when they were on the pre-mix insulins, their sugars could go high post-meal. But today, now, when the children are on basal bolus, I know there's a basal dose of insulin going, and with the bolus, we can adjust. If the child wants to eat that extra roti, we do allow the child to eat, and we teach them that, okay, for this extra roti, you need to take so much of insulin. So, again, it helps in the overall management of type 1 diabetes. Now, why do we count carbs? Because carbs have the greatest short-term impact on blood glucose levels, and protein and fat takes up to 2 to 3 hours to show up as blood glucose. Honestly, in our Indian home cooked meals, we really don't eat so much of protein and fat. So it doesn't have an impact, but it does have if we see like a meal that we ate today. Definitely there is more amount of fat and there could be more amount of protein, because if you eat the rasgulla and you eat the fish and maybe 2 servings of fish or chicken, of course we are going high on our protein and fat content as well. And therefore there you would need to take additional amount of insulin. Sometimes our children eat pizzas or burgers or, go out and eat Italian, Chinese, Mexican, etc., etc. You have so many different kinds of cuisines which are available today. And therefore there they would definitely need to take additional bolus for the fat and protein. SMBG and CGMS becomes very, very important, especially to guide decision making. So our patients are on either CGMS or they are on SMBG, depending on what is affordable. And that definitely helps to guide the decision making. Now, who can do carb counting? It is those children who are on a separate dose of basal and bolus. So separate basal bolus, so basal bolus therapy. Pre-mix insulin, you can't really do it because then when you increase one type of insulin, you're also increasing the other. And most of our children today, and even the guidelines very clearly state that children with type 1 diabetes should be on a basal bolus regimen. Now, how do we start with carb counting? I think very important is starting from the basics. Recognition of foods which have got carbs and which foods do not have carbs. I know a lot of people who think that dals have no carbs. They think dal is only protein. Oats has got protein. Ragi has got protein. So a lot of misconceptions around food. So we have to start there. So which foods have carbs, which foods are lower in carbs, and which foods have no carbs at all. Sometimes you get a spoon of butter and they say, okay, how much should I bolus for it? Or I have, one picture of an egg and it'll be, okay, how much should I bolus? But egg does not have any carbs. Eggs is pure, protein and fat. Again, when you look at butter or, oil, it has got fat in it. Healthy versus unhealthy carbs. This is again very important because then they will send you pictures of a muffin. Every day there'll be one different thing and they'll say, okay, now tell me what is the carbs, because they think it's very simple. I just do the ICR and I can bolus it. So of course the focus has to be on eating healthy carbs most of the time. And we follow the 80-20 principle. 80% of the time eat healthy. 20% of the time you can indulge, but very important is you should know how much insulin you're covering it up with and when to do it. Estimation of portion size, because again, like you saw, I was talking to Preeti ma'am today at lunch, the rasgulla, it can be different sizes. So the rasgulla today was pretty big, but you can have these very small, it's called goti rasgulla also. So, again, the carb counts would vary. So when you're getting those pictures, you really can't make out, what is the exact size of it. So there's so much of variation. Even if you look at our own chapatis, every household chapati measure would change, whether it's in the thickness or whether it's in the diameter. So again, we make them do that exercise at home, and it's a one-time exercise where they measure their chapati atta size and they tell us, and then we know that this is what it is. Use of resources. Today we have a lot of resources. In fact, at ISPAD also that we've developed a resource. One is for India. We've got one for Pakistan, one for Ecuador, Mexico, and now we're working one for Bangladesh. So, we're developing carb counting resources for different countries. Of course, you can't get everything because in India, I think you just can't get all the foods in one booklet. And it's very, very difficult, but at least most of the commonly eaten foods that we have included. Practical advice about what to eat away from home, because today menu cards are available. So, the families do tell us what they're eating. Use of insulin to carb ratio. Of course, SMBG and CGM has become very important. Now, these are what are the foods which contain carbs. So, whether it's all your grains. Today, a lot of people have switched to millets, and that is what we've seen commonly. Last year, we celebrated the International Year of the Millets, and everybody went and switched off from their rice and wheat to millets. and they think millets have got no carbs. Millets have similar carbs and similar nutritional content. Of course, a little bit more polyphenols, your fiber, and something here and there, but more or less they are very similar. Starchy vegetable. Again, when you ask people what you eat, it's sabzi roti. So what is the sabzi? Aloo ki sabzi. So again, there the carbs would vary. So talking about starchy vegetables and non-starchy vegetables, because the starchy vegetables would have more carbohydrates compared to the non-starchy vegetables. All your pulses and dals. In fact, 30 grams of a dal, raw weight of a dal would give you 15 grams of carbs. So people do not think that it does have more protein, but it also has carbs. But they're good carbs and they should be included. Your fruits and simple sugars. Again, a lot of people think that, dates, honey, brown sugar, all that is very good. And in fact, they start substituting their sugar for this. But the amount of carbs and calories is the same. Sweets, again, when we talk today, a lot of people go and opt for yogurt in the market. And most of the yogurt outside is flavored with sugar. So if you see one small tin of yogurt outside, it may have even 16 to 18 grams of sugar, which is like a lot of it. Makhana, very popular, your popcorn, all these are your carbs. Again, milk. Milk does have carbs. Your curd does have it. So we'll discuss it in detail. Now, these are the 15-gram portions. This is from our carb counting book, which we can share it with you. We have this in our clinic. I think this is very important. In fact, we give it to every family who comes to our clinic because we want to onboard them from there itself. So, they get a measuring cup, they get these measuring spoons because again, the dinner sets, if you see the bowl size also has become very different. It used to be a small bowl. Nowadays, you have these bigger bowls. So if you tell somebody eat one bowl, you really don't know because you're talking about the bowl that you are thinking about when actually the person is thinking of the big bowl. So there it said the portion control would vary. Your spoons, then it comes to your food weighing scales. In fact, in the new carb counting book, we've actually mentioned weights of the foods as well. So, it becomes easy that that if you take 110 grams of cooked rice, it roughly gives you around 30 grams of carbs. If you take 40 grams of a roti, it roughly gives you around 15 grams of carbs. So it becomes very simple for people, for them to weigh the food. And it's again, not very inexpensive. So we do tell them where to get it from. Now, these are your exchanges. So basically, I think it's getting hidden. But yeah. Yeah. So if you look at cereals and millets, this is our exchange list that we followed. In college, this is our Bible. This is the most important thing. So, roughly, if you take around 30 grams of cereals and millets, it gives you around 100 calories and 22.5 grams of carbs. Of course, a little bit up and down, but this is what it is. This is from the IFCT that we have taken. That's the Indian food composition table. Pulses, 30 grams would give you around 15 grams of carbs. If you, it's not working. Someone's there to help? Oh. Okay, this is working. So I'll just talk from here. It's fine. Okay, so basically, if you look at soya bean, it's very low on carbs. But very important is that we tell them to soak the soya bean, sun dry it, then roast it, and then use it because it does have certain goitrogens as well as certain anti-nutritional properties. So they get destroyed in it. But if you look at it, it becomes a very good snack. In fact, what we tell a lot of our children's families to do is you take the soya bean, you soak it overnight, you sun dry it, you roast it nicely, and then you can put some flavoring and have it like how we have chana, roasted chana. So again, it's a low carb snack, again in moderation. So we tell them how much they can consume. Milk and milk products, again, whether it's milk or paneer. You see 100 grams of milk roughly gives you around 6 to 7 grams of carbs. Vegetables, again, different kinds of vegetables, whether it's your green leafy vegetables or whether it's your starchy vegetables. Fruits, again, different sizes of fruits. It will differ. So, people think papaya is very healthy and then they go and have a whole papaya and wonder why their glucose levels have gone up. So we have to tell them how much fruit. And of course, fruit juice is only when in a hypoglycemia situation. We really don't encourage, and we tell them we don't encourage even children without diabetes to have it. So what we're telling you is what we would tell any other child to have. Sugar, I've already discussed it, whether it's honey, because a lot of people actually will switch. They will start making brownies and cakes out of honey and jaggery and then wonder why is their glucose going up. So it is the same. Now we calculate the carbohydrate factor of a food. This is from, suppose we're having a food label, then you look at what is the carbohydrate. Now it's mandated by the FSSAI to actually mention the amount of fiber, to mention the amount of added sugar. Because in the past, they would not mention added sugar if it was jaggery or if it was honey or maple syrup or any of it. Today, it's mandated that you have to mention it separately. So here, if you look at it, carbohydrate is 28 grams and fiber content is 5. So you minus the fiber from the total carbohydrate, you get a net carbohydrate, which is 23 grams. Now, you then divide it. So 23 grams of carbs is there in 34 grams of bran flakes. That means every gram of bran flakes is having around 0.68 grams of carbs. So that becomes very easy. So suppose somebody is having, say, 40 grams, you do the factor, you just multiply it, and you can do it for most of our foods that are available. Some commonly eaten foods. Now, this is what I'm going to, show you in terms of different kinds of foods that are commonly eaten in our country. Thepla, rice, one roti, a half cup of rice. So 1 cup of rice, the measuring cup that I showed you is roughly around 30 grams. So half cup of rice is around 15 grams. And this is for all rice, whether it's parboiled or we've done that exercise as well. One slice of bread is roughly around 15 grams, half paratha again, depending on the size. Moong dal or besan chilla. We do emphasize on having a lot of pulse-based items, and we do have them in our Indian cuisine as well, whether it's a mixed dal chilla, etc. One dosa, 15 grams of carbs, two small idlis, 15 grams of carbs, and oats. Again, very important, I want to emphasize here is that even if you count the carbs right, each of these carbs will elicit a different glucose response. For example, idli, dosa, because it's fermented, it's a good process because it does make your nutrients bioavailable, but it also makes the glucose more available. And therefore, we do see a spike in glucose post eating an idli and dosa, and the person may need to bolus extra insulin for that meal. We don't really tell them don't eat it. We just tell them, okay, we'll look at the trends and maybe you need to bolus a little extra for that meal. Similar with oats, you have different kinds of oats available in the market. You have instant oats, you have rolled oats, and you have steel cut oats. So steel cut and rolled oats is a better oats to buy. So, we go even into terms of grocery shopping, what they need to pick up. So it's a lot of detailed, counseling and, sessions that we have with these families. One millet roti. Now, this is very important because people switch from their regular chapati to a jawari bhakri or to a bajre ki roti or to a ragi roti. But, the amount of carbs could be actually much, much more. And then they wonder, why is my glucose going up? In fact, ragi has a very high glycemic index. And today, most of the millets that are available in the market are all polished millets. So they do elicit a higher glucose response. And this is proven by studies which is done by Dr. V. Mohan and team down south. So again, there the exercise of calculation becomes important. Again, when it comes to your upma, poha, breakfast cereals, they again elicit a higher glucose response. And therefore, we have to tell them as to how we can blunt the GI. Add some, peanuts to it. You can cook it in buttermilk. Add some vegetables to it. So that way, the glycemic index goes down as well as satiety is achieved. Makhana, puffed rice noodles. Makhana is very popular, but very important to remember, it's very expensive as well. So not everybody can afford makhana. So please look at the affordability of the person before we do prescribe it. There are other economical options as well that we can give these children. And I'm sure it's going to be discussed in the next presentation. Okay. These are again dal. Dal can again be very different in terms of carbs. Because if you do thin dal, it will have lesser carbs. You do thicker dal, it will have more carbs. A dal makhani will have a lot of the carbs as well as the fat. So all our dals, whether, you look at the length and breadth of the country, the carb counts will vary. In fact, the region that I come from, the western part of India, they add jaggery and sugar to dal. They like everything sweet. In fact, their vegetables have also got sugar. So you have to count that also. So, while we're taking the dietary recall, all these questions need to be asked because a Gujarati family will always add sugar or jaggery to their dal. Sometimes even to their raitas, even in the eastern part of India, they would add. Sambar again, some places sambar is with sugar, some places sambar is with without sugar, some places it is with jaggery. So the carb counts would vary. Potato again will have carbs. Now these are the foods which have got low or no carb. So if you look at clear soup, again, soup can be either clear or it can be with cornstarch or with some kind of a bulking agent. Sometimes they add a potato to bulk it up. So again, very important is when they're going out, we tell them to ask the chef, what they're doing. And at home, we prefer if they're having a clear soup. Fish, if you're having less than, again, this is very important is when do you say a food is low carb? When it has got less than 5 grams in one serving, what the person is eating. I remember telling our family that you can have curd, in between, because the child had celiac as well as type 1 diabetes diagnosed and, was very hungry. And I said, okay, you can give a cup of curd. This family was giving 1 kilo curd at a time. So it was definitely going to elicit a higher glucose response. So very important is how much, because they feel, okay, paneer is low carb, I can eat how much I want. So portions, how much to eat is very important. How much is low carb? And that is what you have to specifically write and give them. Handful of nuts and seeds. Again, when we tell them to have nuts, they will have dry fruits. So they think nuts and dry fruits are the same. So they will, instead of having almonds or pistas, they will go and have dates and anjeer and apricots. Again, the carb counts are very different. So dry fruits do have carbs, whereas nuts are low in carbs. So even when we speak, we should say nuts and not dry fruits. Dry fruits are good only when a hypo situation is there, or maybe if you want to keep the glucose levels stable, maybe with nuts. Now, these are again your big list of low and no carb. And honestly, there's a lot that you can give them. There's so many recipes, even a rasam for that matter, is a low carb food. A dahi kadhi, like today there was dahi kadhi. So if I just took the dahi kadhi, it would be low carb. But if it's with the pakoda, yes, then the pakoda would give the carbs. So these are foods that are lower in carb. And why I'm mentioning this is because if I'm replacing one day a dal with a dahi kadhi, the carb count would go down. So therefore, the insulin requirement could go down, or I add something to keep the carbs consistent. So that is what we, when children love potatoes. So we say, okay, you want to eat a potato, then the day you're not having a dal, and then we're having maybe a piece of fish, that is where you can add the potato. So that your carbs remain consistent, you take the same amount of insulin, and the child still enjoys the potato. And today you know that, okay, there's resistant starch as well. We tell them to boil the potato one night prior, the 24 hours, if you boil and keep it in the fridge and then cook it on a low flame, it has resistant starch. And in fact, it elicits a lower glucose response. So there are a lot of things, similar with your rice, with your pasta, and a lot of things. I mentioned this in my book as well. It's, on resistant starch. Again, we don't really have to. A lot of parents switch to different kinds of milks. So instead of, milk, they will start having oat milk, and they will have almond milk and soya milk and all of that. It's not required at all. So we don't encourage it. In fact, the protein content in those milks is very low. And in fact, the carb content in oats milk is very high. And again, you have to look at affordability. All these things are extremely expensive. You're not going to sit and make it at home. So it's not something which is something that you can do on a day-to-day basis. We do not want to add on to the cost or to the effort. Already the parents are putting in a lot of effort managing the condition. So we have to keep it as simple as possible, as regular as what they would ideally be eating at home, and keeping economics in mind.
May I interrupt, Sheryl? Yeah. Last 2 minutes, please.
Oh, okay. I think I'm just, okay. I'll maybe 5 minutes if I can do it. Oh, I can't? Okay. Then I'll just quickly go through it. So decoding nutrition labels is very important because a lot of things are sold as sugar-free, fat-free. So this is something that we need to educate on. Yeah, the last 2 slides, I'll just talk on this and I'll stop. So one is total daily dose. So we calculate the entire dose of the day. That is, what is the amount of basal as well as bolus that the child is on. And of course, this will change with time. So we keep having to review it. And we use the formula either 450 or 500. So 500 divided by total daily dose if it's a fast acting or a rapid acting insulin, and 450 divided by total daily dose if it is a short acting insulin. And for very young children, we could use the formula between, but this is just the starting point. This will change and this will be different for every child. Sometimes the children need more insulin in the morning because there's more resistance, and lesser insulin in the evening. So this would be something that we would have to work on with every child, depending on what we see in terms of the CGM trend reports. So this is how we would arrive at it. So 15. Now this is 2 plates, which I'm going to show you. One is a plate which has got dal, and one is a plate which has got fish. So the carb counts would vary. And therefore, the amount of insulin, if you're looking at 1:15 ratio of carbs, it would be maybe 6 units of insulin for this plate, whereas if I'm looking at this, it would be 5. I can add a potato here and make it still 6 units of insulin. So this is what it is. If somebody is on a rapid acting insulin, then, before breakfast, before lunch, before dinner, then of course the mid-meal snacks, the person will have to take another insulin in between. And we do emphasize on that, because sometimes parents give very low carb snacks at, in between, and children don't enjoy it. Then they go to their friends, they will eat from their friends' tiffin, lie at home, etc. So we do tell them to take that shot of insulin. And again, the evening snack, it differs. But if the person is on a regular acting insulin, say before breakfast, if the child is on a regular acting insulin, then in between it does cover another snack, but not necessary in all. Suppose they're having a paratha for breakfast. Now, paratha has got more fat. So fat will release the glucose slowly. So in fact, even at that mid-meal, it basically is on the higher side. So you may not really need. So it's again not a one size fits all. You'll have to look at how each food is, in terms of eliciting a glucose response in terms of the time, and then decide whether the child needs to take that snack or maybe, not take that snack in between. So this is something that we would look at. And of course, we do give them options of, low carb snacks, whether it is if they're not taking a shot of insulin. For example, in the evening, they don't want to take that shot of insulin. They're going down to play. So you know that play itself works like insulin. So there we do give them a fruit. Even if it's a mango season, we do give them a mango to eat. We tell them how much. And with that, we give them some nuts or some low carb snack, and it works perfectly well. So this is what we do. And again, when it comes to protein and fat counting, suppose the person is eating a pizza, going out and having a pizza, and suppose 3 slices of pizza. So we know, okay, 3 slices of pizza, roughly around 80 grams of carbs. So what we would do is we would not consider as 80, we would consider as 100. So we take 20% extra, and that's the starting point. So you start with maybe another 20% extra, and then you see, check the sugars 2 hours, 4 hours, 6 hours. And if the glucose levels are coming in the target range, you know that you're doing fine. So this is how we would look at high fat foods. And in fact, for those meals, a regular acting insulin would work better because it does have a longer duration of action. Whereas if it is a rapid acting insulin, you may need to split the insulin to take care of that the late rise in blood glucose levels. If it's a high GI meal, for example, the child wants to eat or insisting on eating a bread or insisting of eating cornflakes, we would always suggest to tell them to pre-bolus. So take their insulin much ahead of time so that that insulin peak and the food peak matches. So that way we get a good postprandial blood glucose. Always we focus on pre-bolusing. But in case of a high GI meal, it has to be bolus well in advance so that, the peak of the insulin and the meal matches. Yeah, thank you.